Good morning. Thank you so much for coming this morning. I am really pleased to not only be presenting the Provonsha lecture, our speaker for our Provonsha lecture, but also doing a symposium. And there are programs which give us a little bit of a background on what we're talking about this morning. So please make sure that you pick one of these up. It has also some quick bios about our speakers, and then a little note from me to sort of introduce the topic that we're talking about in our symposium today. But without further ado, I am so pleased to be able to introduce our speaker for our Provonsha lecture. As a student in the Bioethics Master's program here at Loma University many years ago, I was assigned a book called 6 Theories of Justice that was written by Karen Lebacqz in one of my classes. I still have this book. It is highlighted, there's notes in the margin, and in fact, it's one of these books that when you go back and you read it and you read the notes, it's like dialoguing with a version of your older self. It's actually quite fascinating. But this book is such a gem. It was so clearly written and incredibly approachable, especially for a medical student dipping my toe into philosophy. So several years later, I then had the chance to work closely with Dr. Gerald Winslow in the Center for Christian Bioethics. By the way, if you're seeing this, good morning, Jerry. It's good to see you here. And during the normal conversation of a day, Dr. Winslow mentioned that he wanted to ask his good friend Karen to be the chair of our advisory board at the center. So I was thrilled to realize that Dr. Winslow's good friend and graduate advisor, Karen, was actually Dr. Karen Lebacqz. Actually, I shouldn't say thrilled. I was pretty intimidated, actually, because I I loved your book for so long. And so when I was able to finally meet you in person, I was just floored by how much and much more like your book you are in person. Just gracious, generous, approachable. And so just thrilled that you're here to give our lecture today. I'm also thrilled to announce that Dr. Lebacqz, that you have continued to work in an academic sphere and have worked with one of your graduate students, Matthew Gaudet, to update and expand your book. So now, instead of 6 Theories of Justice, it is now 8 Theories of Justice. And the book is now going to be available April 1st, 2025, in just a couple months. We actually do have flyers here if you would like to also save a little bit on pre-ordering a book. But I would highly, highly recommend it. I've had the privilege of having an advanced copy, and it is truly a worthy successor to the original. So Dr. Lebacqz is a master teacher, writer, and a minister. She's devoted her life to tackling the thorny issues of social justice. She's taught at the Pacific School of Religion and the Graduate Theological Union for over 30 years, and through her academic work has focused on professional ethics, bioethics, especially questions around genetics and the Human Genome Project, and ethical theory, particularly justice, and questions of method and ethics. Her publications include books such as Justice in an Unjust World, Sex in the Parish, and Ethics and Spiritual Care. She has dozens of essays in bioethics, feminist ethics, sexual ethics, published in scientific journals, church magazines, and international contexts. And although Dr. Lebacqz currently describes herself as a, quote, independent arts and crafts professional on her LinkedIn page, she continues to be active in writing and publishing. Dr. Lebacqz has a deep history of service. She served on the National Commission for the Protection of Human Subjects, as a consultant to the Director of Health for the state of California, as a member of the LC-based Genome Project of the Graduate Theological Union for Theology and Natural Sciences, as chair of the Ethics Advisory Board of the Geron Corporation, on other multiple policy-making boards and bodies, as president of the Society of Christian Ethics, and recently recognized by the American Academy of Religion for her contributions to the field of bioethics. She's also ordained in United Church of Christ. And so, Dr. Lebacqz, I can't think of anybody better to dialogue with about the thorny issues that we face in bioethics in such a time as this. Please help me give a warm welcome to Dr. Karen Lebacqz.
Thank you. Okay, first of all, Dr. Lebacqz is also a technological ignoramus, so I need to figure out how to advance my slides when the time comes.
There's a green button.
The green button, there's two green buttons.
The big one.
The big one. All right, and then can I go back? How do I go backward, like this?
Yeah.
All right, we got it. Thank you. You never know. First of all, I want to say welcome to everyone, and thank you for being here, and a particular thank you for the invitation to give this lecture. It is truly an honor. Now, if you are in the field of medicine and you've done any work at all in bioethics, you know that the current mantra of bioethics principles comes from the prodigious work of Tom Beecham and Jim Childress. Their three principles are well known: respect for persons, beneficence, and justice. The popularity of these principles is undeniable. Their value is also undeniable. And I take some pride in the fact that the National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research, try fitting that into any little space you're given on a form, on which I served many decades ago, was at least partly responsible for the development of these three philosophical principles, which are enshrined in preliminary form in the Belmont Report. These principles have stood the test of time, albeit with many emendations over the course of some 8 editions of the Beecham and Childress book. In fact, so popular are these principles and so widely known that last fall, when I was asked to develop a set of principles for my church council to use in addressing important social and political issues, I was tempted to turn to Beecham and Childress. But I have long thought that there is a different base, a biblical base, that also has stood the test of time and provides a good, possibly even a better, grounding for an ethical approach to any social or political concerns. So I used it instead for my church council, and I offer it to you today. It is a biblical approach drawn from Micah 6:8. What does the Lord, the great I Am, require of you but to do justice, love mercy, and walk humbly with your God? So let us begin with justice. I want you to notice first that for Beecham and Childress, justice was the third principle, but when we turn to Micah, justice is the first requirement. My life's work has been about trying to understand what justice requires and what it would mean to bring it about. And frankly, I still don't have a definitive answer. I think that it is quite appropriate that the updated version of 6 Theories of Justice, which is now 8 Theories of Justice, it could have been 28 or 78, there are so many today, but I think it's very appropriate that it is being published on April 1st, which is April Fool's Day, because I sometimes think that only a fool would seek justice in this day and age. But I hope that some of you will find it helpful for what it gives you. The classic philosophical statement for justice, there are 2 formal principles. One is give to each what is due, and the other is treat similar cases similarly. Now, each of these formulations seems to me to imply some respect for persons, so I don't think that Beecham and Childress's concern for respect for persons disappears when we turn to Micah. I believe that the requirement of respect for persons with its derivative norms of informed consent and right to refuse treatment can be incorporated into the requirements of justice. The problem, of course, is determining the grounds on which something is due to someone, or determining what it means for cases to be sufficiently similar that they should be treated similarly. Need, merit, the common good, utility, all of these vie for pride of place as the criterion for what justice might require. In the medical arena, Jean Outka argued many years ago quite forcefully, and I think rightly, that need rather than ability to pay should be the most important criterion for distribution. You should get medical care when you need it, not just when you can pay for it. Oh, that sounds good, but there are still problems. There are problems of access. Unless you can access medical care, you can't get what you need. There are problems of assessment. Once you are in the system, are you evaluated honestly and appropriately? And of course, in our system, there are problems of payment, because in our system, access to medical care is often linked to employment. Quite frankly, folks, in the last few weeks, we have seen at least 100,000 people lose their jobs, and this is a health care crisis. It's not just an unemployment problem, because when people lose their jobs, they often lose their access to health care, not only for themselves, but often for their entire family. And so yesterday, the headlines of the New York Times included an article on the uneven distribution of organ donation, in spite of the many rules and regulations that are supposed to ensure that organs go to people on a just or fair basis. It should come as no surprise that, generally speaking, it is privileged white people who get the organs, even though the system is supposed to ensure justice across color lines. In a biblically based view, I think justice is both broader and deeper than the philosophical formal statements. The way I like to put it is, I think justice gets exploded and imploded. So we're going to start with the explosion of justice. If justice requires that we give to each what is due, we have to ask, on what grounds is something due to somebody? What makes these cases similar or dissimilar? I believe that the Bible has a distinct bias and perspective that helps us answer this question. While the philosophical literature simply speaks of giving to each what is due, the theological literature on justice speaks of an option for the poor, or an epistemological privilege of the poor and oppressed. The God of the Bible is a God of the oppressed. Justice requires liberating the oppressed, and justice becomes Amos's upwelling and ever-flowing stream. I once lived in a small parsonage that had a little stream in the backyard. My year there turned out to be an El Niño year in California. It rained, and it rained, and it rained some more. And the little stream in my backyard grew and grew. It became not just a stream, but a creek, and eventually a river. Entire trees were swept off down that river, and I stood in my kitchen looking out the window and wondered whether my little house would stand and when I might need to evacuate. This is Amos's justice, a mighty stream that wells up and completely changes the landscape. Justice can require the complete undoing of systems, not simply tinkering with them to make them a little better or a little bit more fair. The question then becomes, are we helping to liberate the oppressed? Are we standing with the poor? Are we listening to their perspective and trying to bring about justice in a way that honors their knowledge? Are we advocating for them? Are we practicing in such a way that our practice will help to bring about God's liberating justice? Who gets privileged by the system in which I work? Can it be changed to privilege the poor and oppressed? In this day and age, for example, doing justice might mean providing health care for adolescents who are experiencing gender dysphoria, even when doing so puts you at risk. Doing justice might mean enabling a woman to have an abortion, even though it is illegal where you live. Doing justice might mean vaccinating the poor, even when federal funding for your institution might be at risk if you do so. This is what it might mean to stand with the poor and oppressed. This is how justice explodes when you look at it from a biblical perspective. But I also think that in a biblical perspective, justice gets imploded, and by that I mean that it gets taken into ourselves. Justice needs to become a constitutive part of who we are, not just an action or a state of affairs to achieve in the world, but a virtue. In classical Roman Catholic thinking, justice is a cardinal virtue. That means it is a virtue on which everything hinges. Roman Catholic theologian Joseph Pieper argues that justice holds foremost rank among virtues, while other virtues such as courage or patience, one of the ones that I am still struggling to acquire, courage or patience have to do with our relations to ourselves. Justice has to do with our relations to others. Hence, justice takes priority over virtues that are just self-reflective. I agree with Pieper, and I think Micah's ordering of commands suggests the same. But I would add that failing to be just not only hurts things in the external world, but it also affects our character. Every act has both social and personal consequences. To be our best selves, to be the people that God has called us to be, we must delight in doing justice. I join Pieper and also Reinhold Niebuhr and others in thinking that a biblical approach to justice will always be tinged with kindness, that justice must have a hint of mercy in it. As Reinhold Niebuhr once famously put it, justice that is only justice is less than justice. The tit for tat, or give to each what is due, of philosophy runs the risk of deteriorating into a stingy, mean, give only what you absolutely must. We are called not to be mean or stingy, but to give generously and willingly. And so we come to Micah's second principle: love mercy, have compassion. The philosophical principle elucidated by Beecham and Childress is beneficence, doing good. And of course, that principle is usually understood to include its companion, non-maleficence, avoiding harm. Primum non nocere, first, do no harm, is still quoted in medical circles and codes. But who determines what is good? There is a certain paternalism allowed in a formula such as do good. To some extent, that makes sense, because surely the one with greater medical knowledge should be the one to determine what is good and how it is to be done. And yet, we also know that much medical practice does indeed do harm. This is inevitable, and it is not wrong. I'm a cancer survivor. I am 100% grateful for the medical interventions that I endured in order to destroy my fast-growing HER2/neu positive cancer and give me the life that I now have. It is my hope that cancer treatment today is easier and better than it was in my day, but I know that even today, repeated rounds of chemotherapy do indeed do harm. There's no way to avoid harm in some medical practice, and so beneficence elides into cost-benefit analysis. Are we doing enough good to justify the harm? This is common reasoning in medical practice, and it is not wrong, but I think it is limited. There is something missing in cost-benefit analysis and in beneficence. In my nearly 80 years of living, I have had several very painful diagnostic procedures. I was raised in good Norwegian style to be stoic, and I am a tough woman. I make every effort to suffer those procedures without complaint. I do not scream or cry out as I have heard others do. I try not even to groan or whimper. On one such occasion, I shut my eyes, clenched my teeth, and held so tightly to the table on which I was lying that by the end of the procedure, I was shaking with the effort not to scream. When I opened my eyes, I saw my doctor standing there with tears in his eyes. He knew that the procedure hurt me. He had told me that it would. He had cautioned me, and we both understood and accepted that to do good in the long run, I had to endure some pain in the short run. But clearly, it hurt him to hurt me. He had compassion, from the Latin compatior, to suffer with. He suffered with me. No wonder that man was voted Kaiser's best doctor year after year. Micah's second principle is love mercy. Mercy, unlike beneficence, I think has an element of compassion that includes the ability to feel another's pain and to suffer with the other, not just to do good for the other. Mercy seems to me to imply a connection and a recognition of the other's circumstances, and even possibly a feeling element that can be entirely missing in beneficence. Loving mercy means having empathy. Now, I acknowledge that empathy is somewhat controversial in medical circles. Last October, Scientific American featured an article on empathy. Empathy takes a toll. Where sympathy might seem, okay, you can stand back at a distance, empathy requires an effort to understand and experience from the other person's perspective. It takes effort, and some have argued that it's a bad idea because it can erode the kind of rational thinking needed for good decision-making. I recognize this problem, and I am all for rational thinking. When I was teaching full-time, I always wore this button that says, think. My students got so tired of it that eventually they went out and bought me a button that said, feel. They were right, because empathy has an important role in good medical practice. One of my favorite TV shows is Untold Stories of the ER. In this show, doctors who have children themselves often refuse to give up when they learn that a patient is a parent of a young child. And they keep going even though it seems as though there is nothing that is going to work. But because they have children, they understand how crucial that family dynamic is and what this crisis means in the life of a patient and for the patient's family and children. Sometimes it's empathy that keeps us going in the face of what seems a hopeless situation, and sometimes hopelessness can turn into hope. Micah's third principle is humility. Walk humbly with your God. In philosophical circles, so effectively promulgated by Beecham and Childress, I don't see anything related to humility, but I think there are three arenas in which humility must be present in medical practice, and the first of these is well known and enshrined in most medical codes. Every good healthcare provider knows that one of the hallmarks of good medicine is knowing the limits of your own expertise and when to refer patients to another provider. In Untold Stories of the ER, it is frequently the case that the diagnosing physician in the emergency room asks for a specialist to come, and part of the crisis is that the specialist is not available. Either the specialist is already in surgery or they're caught in a traffic jam and they can't get to the hospital in time and we have only a few minutes, or this patient is going to die. And so now a person who is not well trained has to do a procedure for which they have not been well trained. And this is part of the crisis that happens in the emergency room. Knowing the limits of your skill is one mark of humility, and it is often included in professional codes of conduct. But I think there is a second arena that isn't so often included in codes of conduct, and that is humility in the face of the patient, because only the patient really knows what a medical procedure, and sometimes, very importantly, its aftermath. Physicians, and especially surgeons, always want to tell you what the procedure is, but from the perspective of a patient, what may matter most is what is my life going to look like in the days, weeks, months, and even years after this procedure. Only the patient really knows what this procedure will mean in their life. Medical professionals need to remember that what seems routine or ordinary in their practice is not necessarily routine or ordinary at all to a patient. I don't remember what procedure it was many years ago that I was told I had to have, and my doctor said, "Don't worry, it's routine." And I said, "Not to me, it isn't. Maybe it is to you, but not to me." Similarly, what might seem a small risk to a medical professional, take, for example, the 1% risk that thyroid surgery will damage the nerve that serves your vocal cords. Okay, 1% risk is pretty small chance. The damage to the vocal cords, if it's there, doesn't keep you from speaking forever, but it does mean your voice is likely to be hoarse. Seems like a pretty small risk. It's not a life-threatening risk. But to a patient for whom singing is central to the joy of their life, that 1% risk might loom extremely large. So when we talk about risk or risk-benefit, we need to remember that the professional perspective and the patient perspective are not always the same. Furthermore, patients sometimes feel things that they have a hard time putting into clear language, but those feelings that something is wrong can be a signal that something has been missed, despite all the blood work, EKGs, ultrasounds, and other medical tests and procedures that are commonly used today. The best medical care begins with careful listening to the patient's story, as frustrating as patients sometimes are in their meandering renditions of their stories. At root, humility means acknowledging that the other person has some knowledge that we need precisely to make the best judgment about what we ought to do. The much vaunted informed consent in medical practice is intended to pick up respect for the patient's perspective, but informed consent is really focused on being sure that the patient understands what the provider said. It has nothing to do with being sure that the provider understood what the patient said. And I think we might need a principle that goes in both directions. Humility brings with it not just standing back and allowing the other to decide, but it allows for a genuine partnership. Finally, there's a third arena for the exercise of humility. Micah's command is to walk humbly with God. The third arena for humility is the broad view. Zoom out, as a colleague of mine would say. How does my little corner of the world fit into the broader picture of what God is doing and what God wants? How does my work serve the justice that God wants and that is the first principle in Micah's mantra? Now, part of humility, of course, is acknowledging that we never know exactly what God wants. Only the great I Am knows the fullness of time and the completion of history. For that very reason, we should be wary of our claims to knowledge, especially wary of any claims to superiority, and even of our sense that we have done everything just right. Every justice that we bring about will carry within it some injustice, and we would do well to remember that. I sometimes think of it as a pendulum that swings in one direction. We try to correct it and we swing it back, but usually we miss the mark and we go too far, and then we have to swing it back again, and we almost never get it exactly right. There is always room for improvement. So there you have it, friends. Do justice, love mercy, walk humbly with your God. Justice, mercy, and humility, Micah's 3 admonitions that I believe would serve us well as principles for biomedical ethics, not just principles for church people. They seem to me both broader and deeper than the philosophical principles that are so well known. They add the dimension of humility that seems generally missing in Beecham and Childress. They require justice to be the first principle, not the tag-on at the end. And I do believe that they would provide a good basis for a biblical approach to a principled bioethics. Thank you. And I think we have a little time for questions.
Indeed. Thank you so much. If you have questions, yeah, please. Actually, I'm not sure where the...
I'm going to be running the mic for you.
Oh, okay. Dr. Lowe will be running the mic for us. Thank you so much. So, Dr. Lebacqz, you speak of a exploded and imploded basis for a biblical understanding of justice. How has that, as you have worked on this expanded and updated form of your book, how has that come through? How have, either an exploded understanding or imploded understanding, how has that informed your writing?
Well, I think for me, as you could probably tell from what I said about justice, I do see liberation, I see oppression and liberation as central and key categories to an understanding of justice from a biblical perspective. And oppression and liberation are not terms that are used a lot in the philosophical literature on justice, even if you read all 78 or whatever more books there are now in philosophy about justice. So for me, the key element here is needing to ask where oppression is happening and what would it mean for things to be liberated, for people to be liberated. So that to me is the explosion of it. It's not sort of look at this, see if they are similar, ask what we owe here, what we owe there. It's ask, where is the system itself going wrong, oppressing people, and completely needing to be upended and overturned? So that can happen, for example. I mean, I think it is, I had dinner last night with a friend down here whose son is a medical researcher. I hope most of you know that most medical research right now has been put on hold because the funding that has been allocated by Congress is not getting to people. Medical schools are thinking of shutting down their admissions. We have a major, major, major problem going on that isn't just about tweaking the system here and there. It really is about looking at the system as a whole and asking, what can we do that opens it up so that liberation can happen? So that, to me, is the explosion of it. And the implosion is that it needs to become that crucial for each of us in our own hearts and our own thinking. So let's take the next question.
I have a question here, but let me set up the rules and regulation for Q&A so that everybody does get a chance to answer and ask the proper question. Question should be less than 30 seconds. Answer should be less than 1 minute so that everybody get to have a lot more, because you're such an eloquent speaker. We want to hear more from you. But also, if you can make sure to repeat the question, since this is actually online, make sure you repeat the question so that we can, the virtual visit people can see it there. Okay, here's the first question.
Yes, thank you very much for the lecture. Karen, would you comment on, further comment on what you see going on in the country today? Supposedly we're making America great, but can America be great when we do what it seems to me is unjust actions in regard particularly in terms of justice, those who were born into this world who are being served for basic necessities of life, and now it seems that we're pulling back from those. This country may not be Christian, that's debatable, but we are humanitarian. What do you make further about what's going on today?
The question, as I understand it, is about, would I say a little bit about where I see injustices happening today and what can, if anything, what can we do about it? And I thank you for the question, because what I'm going to try to keep this focused on the medical arena, but I do see injustices happening across the board today, where those who are poor and oppressed are getting further impoverished and oppressed rather than getting liberated. I think that's very clear in a number of the policies, but I would just point, as I did in the lecture, for example, firing of over 100,000 people at this point. Notice we don't get unemployment statistics anymore because that office has been shut down. But the firing of over 100,000 people means 100,000 people who may not have access to health care at this point, not to mention their families. That is a health care crisis, in my view, and we should all be standing up in protest about it. I'll have to take the next question because I'm supposed to be brief.
Okay, so
hard for a theologian to do, you know.
With regard to oppression and liberation, in regards to lifestyle medicine, often if I try to approach the issue of lifestyle with my patients, they think that I am oppressing them and not liberating them. So I don't know sometimes it's difficult to know how to approach in that regard.
Actually, your question is a very good one. It's about if you ask patients to think about their lifestyle, which the previous lecture here on diabetes was fascinating to me and very much focused on the possibility that we can prevent and even put diabetes into remission with lifestyle. But the question is, if I tell my patients they have to change their lifestyle, they say I'm oppressing them. That, of course, is not what oppression is about. Oppression is not an individual thing that your doctor does to you. Oppression is a social, systemic condition in which some people live. So I would say to you, for heaven's sakes, by all means, ask them, what is it that you think is so oppressive? But there are people, I would say, who cannot easily change their lifestyle. People who are impoverished and are getting their food, for example, from food banks, really don't have the option to go out and eat that healthy lifestyle that we might like everybody to eat. So some of us have a lot of control over what we do with our lives. Some people do not have that same level of control. Next question.
Right here.
Thank you very much for your very thoughtful presentation. One of the things you mentioned that resonated with me a lot was the issue of informed consent. So we had a bioethical legal session prior to this yesterday afternoon, and they talked a lot about informed consent. And you're right, it is indeed about making sure the patient understands what the physician has said. Can you tell us a little bit more suggestions, maybe in your ideal world, how would you make that ensured that the physician understands what the patient is saying?
The question is about, I mentioned that informed consent goes from physician to patient. Does the patient understand what the healthcare provider said? But I would like to see something that goes the other way. And it could be as simple as requiring a change in the system that gives healthcare providers more time to listen to their patients, because patients often ramble. You know, we don't tell our stories in some neat, tight order from A to B to C to D. We ramble, and you have to cull out of that. What is it that's really going on? But there are crucial lifestyle issues that might have to do with things like, is somebody long-distance truck driving and therefore sitting in a very awkward position hours and hours and hours every day that tends to end up giving them back trouble, for instance. So until you know what is going on in the patient's life, you really don't know exactly where your intervention is going to be the most helpful. Way in the back.
Yes, thank you for the presentation. You did mention justice, and I know historically justice has been equality under the law. In other words, no matter how wealthy you are, no matter how poor you are, everyone needs to be able to keep the law, and that's the equality basis. In modern America, the equality is actually now rated as equality in outcomes. And in order to have equality in outcomes, if we're going to measure whatever outcome that is, we have to be disequal in regards to the treatment under the law. How do you balance those two?
It's a wonderful question about when I speak of justice. Could justice be encompassed by equality under the law? And there's two ways of understanding that. One is equality of sort of treatment under the law. Everybody gets equal treatment. But the other is equality of outcome. Clearly, in the medical field, it seems to me that what you're looking for is more equality of outcome. So what you want is as good a life as possible for every person, making it as equal as possible to others. So if you take a child with disabilities, for example, you will have to give that child child, maybe more treatment than you would give to another child in order to give them that better chance of a better outcome of life. So for me, the equality, I think I prefer the term equity to equality, because equality does have that implication that it's all the same. And indeed, what we're really looking for is an equitable situation where the outcome makes sense. Is there another question?
I have a question here. Maybe we'll consider this a second to the last question so that we can actually have a bona fide break until the next one, which is a 10:20 lecture, so that they can all go take a break for a minute. So 2 more questions, and that will be it, okay?
Okay.
You mentioned, you used 2 examples of when justice might require, for instance, the provision of gender-affirming care or an abortion. Both of those might be problematic for the provider or the institution. So how do you balance the right of a physician, for instance, or an institution to refuse something that the patient might be asking for?
It's a good question about balancing justice as a patient perhaps should get a certain kind of care with the physician's right to refuse to give that care. I have no difficulty with the idea that people can refuse to give certain kinds of care as long as they can make sure that their patient has access to it elsewhere. But that's not always possible for patients. And my concern here is to suggest that there are moments where you have to act courageously and stand up and say, justice requires me to do this, even though I realize there may be punishment to follow, even though I realize there may be sanctions for me or for my institution. It's easy for me to say that because I am not a healthcare provider. I realize how very much more difficult and problematic that would be for anyone who is a healthcare provider. So I thank you for the question, and I know that's not a total answer, but it's my quick answer.
Thank you so much. One last question. Yes, you have to go all the way down onto the other side, don't you? Just give me 1 sec. Okay, you go for it.
What would you use from the Bible that we could go home and read to apply to your message this morning about justice, mercy, and humility? Would the statement made in the Bible,
I made it.
thank you. Would the experience that Jesus had at the Pool of Bethesda would be applicable for us to apply to what you said today? When Jesus came to the Pool of Bethesda and he saw the man that could never get down to the movement of the water in the pool to get healed, what did Jesus do? Is that applicable to apply to what you talked to us about this morning?
The question, if I understood it correctly, is what did Jesus do that relates to these 3 principles that I've drawn from Micah? Part of the reason I draw my principles from Micah is that by drawing them from the Hebrew Scriptures, they are principles that apply not only to Christian bioethics, but would also be principles that would make a lot of sense to my Jewish colleagues. So I do that very deliberately, but clearly Jesus was extremely merciful, and Jesus also called for justice and worked for justice and brought about justice to the extent that he could in his lifetime. So I don't think there's any question about that. And in terms of walking humbly with God, can't think of anyone more humble than Jesus when he says, "Forgive them, they know not what they do." If that isn't about as humble as one can get, I don't know what is. So that the humbling oneself, not just before God, but even before those who oppose oneself. So I thank you for the question, and I do hope that all of you will take that as a challenge for yourselves to think about in your own reading and work with the Bible. What does it tell you that is significant for your work if you are a medical professional of some kind? What do you think is implied for the work that we do in the healthcare arena, and how can we enrich that work by bringing the Bible to bear as a base for bioethics? Thank you.
Thank you so much, Dr. Lebacqz.